Hello and welcome to another episode of CRNA School Prep Academy podcast. I'm your host, Jenny Fennell, CRNA, and today we are going to discuss what are the differences between ICU nursing and being a CRNA. I have a lot of ICU nurses who discover the path of a CRNA, but really truly don't understand what the differences are and maybe even what some of the benefits are from being an ICU nurse to a CRNA. So I just want to kind of preference this that, while this is my own personal opinion, I'm going to share with you guys kind of why I think ICU nursing and CRNA, while they're similar, they're also very different. And if you're like me, I did not like being an ICU nurse. So if you're worried, if you don't like being an ICU nurse, or you're not going to like being a CRNA, I'm here to really reassure you that that's just not the case because the jobs are actually very different. I like the ICU for some reasons and not for other reasons. I was very fortunate in that my ICU experience was amazing. I had a really amazing staff that welcomed me on with open arms. I was a nurse's aide on the unit prior to being hired on the medical ICU. And they had phenomenal staff. The senior nurses that were there were just so awesome and again, welcoming. So I got very lucky. I know that's not everyone's experience. I've heard some unfortunate stories of the ICU from some of my students, but that being said, I can tell you that that's not always the norm. So know that if your experience has been bad in the ICU thus far, know that there are good ICUs out there and ICUs that are not necessarily unfriendly. There are ICUs that are very welcoming and very warm, to new grads. And so I encourage you to try to seek that out, maybe by asking around prior to taking a job, asking if current staff is happy, what's the turnover rate, all the types of things you should be kind of looking into, even as a CRNA, when you're taking your CRNA job, what's the most senior staff there? If the most senior nurse they have there is 3 to 4 years, that might say something to you. Like that might be a huge red flag that no one's sticking around long-term. And why is that? So making sure you're asking those hard questions when you're going in for your job interviews prior to accepting the position, I think is really key. And don't just take an ICU job because you think it's like, if an ICU job is unfriendly, meaning if you've heard some not so good stories from previous people, but you think it's the best ICU in town, I'm here to tell you that there are ICUs in various shapes and forms. You don't have to go to the CV ICU. You don't have to go to the SICU. You don't have to go to the MICU. You can get your experience anywhere as long as it's high acuity. And it doesn't necessarily have to be from a trauma designated hospital. As long as the acuity is there, that's all that matters. The reason why level 1, level 2 traumas are most often recommended is because the acuity is for sure there. And there's no question in the program's minds that these candidates are getting high acuity experience. It doesn't, however, mean that a center that isn't trauma designated isn't high acuity. You just have to be able to display that both in your resume, essay, and in your interview. And so again, I want to stress that you don't have to come from a level 1, level 2. And a level 2 essentially is just like a level 1 as far as acuity goes. But that being said, you also need to be asking these questions when you're going in for your interview. How many vasoactive drips do these nurses typically titrate in a shift, in a week? How often are the patients ventilated? Are there opportunities for research? Are there opportunities for advanced life support like ECMO or CRRT or balloon pumps? These are the types of things you need to be asking about. So don't just pick an ICU because you think it has a big name or is a big center. Make sure you're picking it because not only are you going to be supported as a new nurse in a learning environment, but you're also going to be getting the experience you want. So again, you don't want to just pick it based on experience only, especially if you're going to be walking into kind of a not so friendly environment and not thriving there. Okay, so that's my rant for today. But let's get into, is the ICU similar to being a CRNA? And maybe what's the biggest difference between the two? I will save what I think the biggest difference is for the very end of the podcast. So stay tuned for that. So number one, in an ICU, you're either taking 1 or 2 patients. Now, I know with everything and the way things were with COVID over the last year, that may have actually been different. You may have had more than 2 ICU patients, which I think is very unfortunate and unsafe. But I know that just with everything that happened in the last year, there's been a lot of unfortunate fluctuations in staffing and ratios based on what they had to do. So, but typically it's 1 to 2 patients If you really are in a true high acuity ICU, it's typically 1 to 2 patients. Okay. And again, if you have one-on-one, it's usually because you have a patient that's like on advanced life support, like Prisma, or on multiple vasoactive drips. If you have 2 patients, it's because they're less acuity. Typically, that's typically how they made those types of assignments. Now, that being said, there are a lot of times where I had, say, maybe a less acute patient, and then I got a train wreck next door because I actually had the open bed. So unfortunately, there were situations where, that did happen. It wasn't ideal, but if you had the only bed left in the ICU and your other patient was, less, they still required attention. They're still an ICU patient. But now you actually really should be one-on-one with your patient that you got admitted. Sometimes just the way the ball drops and you end up having 2 very decently sick patients to take care of for the vast majority of your shift. Where in anesthesia, you only ever have 1, which is awesome. You never do 2 surgeries at once. You never roll 2 patients back in the OR and say, I'll anesthetize you first and you second. I'll wake you up first and wake you up second. It doesn't work like that. You get to put all of your attention on 1 patient, which really is a very enjoyable thing, to be able to give all your attention and focus to 1 patient and really just dive into their scenario, what's going on with them, and really just put all your focus on 1 person. I know that's one of the more enjoyable things about what I currently do versus what I did as an ICU nurse. As an ICU nurse, you spend a lot of your shift looking through orders, double checking orders, getting rid of old orders, and just, again, reading orders. I felt like I was always reading orders and seeing what new ones were populating. Where in anesthesia, you are not only, you're essentially, you can be writing orders. You're the ones writing an insulin. You need an insulin drip, so you're writing an order for that. You need to write a order for an epidural, that you just placed. So you are actually, as a CRNA, you are writing orders sometimes. You're also spending a lot of time looking over preoperative notes and assessments. You're also doing your own preoperative notes and assessments. You were also looking through the patient's H&P and reading various reports, whether that be echo reports or any kind of laboratory reports. You're kind of getting a really good overall picture of the patient. Like I said, you're really kind of researching the patient and understanding them and what their needs are going to be during the case. And so I think that's way more enjoyable than spending a lot of your shift reading orders. And yes, you have to get to know your patient as an ICU nurse, but I don't, especially when you have more than 1 patient, it's kind of hard to really get to know someone on the same level that you do if you only have 1 patient. But essentially, again, both ICU nurses and CRNAs do a lot of digging into their patients' charts and really trying to understand their medical prognosis and diagnoses and things like that to help them care for the patient. As an ICU nurse, I felt like, you do a lot of, obviously you follow protocol. I mean, you follow orders, you follow protocol. And a lot of times what you do is based on protocol, meaning based on the lab results, you're giving this much potassium. Based on the lab results, you're, requesting an ABG or redrawing some coags or whatever, again, the order protocol calls for based on the results, right? Maybe their heparin's not therapeutic anymore. So again, you're kind of following protocols to kind of judge what the next move is. As a CRNA, you're kind of, it's more independent thought. And essentially you're coming up with a plan that is then tailored to that individual. And you actually collaborate your efforts with the surgeon, with your anesthesia team to kind of come up with that plan. So you're actually making your own assessments and not necessarily following a protocol, but saying, okay, well, that's concerning and this needs to be addressed. And how can we work together as a team to make the best plan of care for this patient? And again, don't forget about your surgeons, and that they play a huge part of what you're doing. And so they're a very integral part of the surgical team and planning for the operation. They tend to know whether they're going to get into blood loss or what kind of stay afterwards the patient's going to need, how much pain they're going to be in. They have a lot of insight into what they're doing. And same with the anesthesia team. You work as a team with other anesthesia providers to come up with the best game plan for that patient. And do they need a post-operative pain control? And if so, do you do that pain block prior to waking them up from anesthesia? Do you do it before surgery? So again, you're kind of working with each other as a team to decide what's the best for this patient and why. So Again, as a nurse, you also come up with the patient's needs. You assess them throughout your shift. You bring up issues during rounds. And again, if anything comes up in between the time, you're always going to get your fellows or your attendings to address other issues that come up outside of rounds. So it's very similar in anesthesia. You're always assessing your patient. You're always, making new plans based on their ever-changing needs. And especially in a big case, things can change. They may be very stable and things are maybe going great. And then all of a sudden, now they have had a lot of blood loss and now their needs have changed. Or maybe the case had to take a shift or change for the worst, and now they're having to do a bigger surgery than they initially planned for. Or maybe they go in there and they can't even do what they initially planned to do. And there's all different types of things that can come up that will make you essentially have to change your plan of care for the patient. Maybe the patient had allergic reaction during induction. Maybe they had, maybe their asthma acted up and they had a severe bronchospasm, and you've had issues with your peak airway pressures during the whole case. There could be numerous things that maybe you weren't anticipating in the patient that now you're going to have to make some changes to continue on safely. So again, similar to in the ICU, you're always assessing the patient and evaluating their needs based on what's currently going on. And really, essentially, what I think is good about working in the ICU that really helps you in your role as a CRNA is always trying to plan ahead. And I actually enjoy that part of my job a lot. I love anticipating what's next. Maybe it's the planner in me, but I like planning my patient's life. Not really, but essentially it's what you kind of do. You kind of say, okay, based on this history, based on this progression that I first foresee, this is what they're going to need. And so it kind of allows you to stay one step ahead. And that way you not only stay on top of their pain control, you stay on top of their asthma if they have it, any other kind of conditions they have that may make their care more difficult. You anticipate what you can do to make it better for them. And you take those kind of precautionary steps to make sure that if you can avoid a problem, you do. And so again, I think that part of what we do is a lot of fun. It's very rewarding, especially when it unfolds beautifully and the patient has a smooth operation with no complications, even though they had all X, Y, and Z that could have led to a lot of different complications. It's nice to know that you took preemptive steps to prevent those things. It's, again, just a very rewarding part of what we do. So as a nurse, you're assessing, don't get me wrong, you assess more than every 4 hours, but you do your big assessments every 4 hours, and you chart those assessments. In anesthesia, it's a little bit different. You're continuously assessing and you're continuously charting your assessment. And so you don't just chart every 4 hours, you chart every 5 minutes vitals. You're always I do 5-minute room scans. So I scan the room every 5 minutes, and it may not be going, back and forth like a robot with my head, but I'm essentially listening, looking, and taking everything in my environment to do these assessments. And so while I may not be like completely doing, a head spin, a big circle, I'm assessing the urine output. I'm making sure the pressure's staying off the eyes. I'm making sure that their head's still neutral. Maybe the surgeon's banging the patient, and so they're coming off their pillow. Now their neck is kinked. Making sure you're taking that time to adjust them. No one wants to wake up with a sore, stiff neck, and making sure, again, their pressure points are, making sure their arm is staying on the arm board, for example. You can tape an arm and an arm board, but if they get jostled around a little bit and they're paralyzed, they're not going to, and they're asleep, their arm's going to fall off the table. So making sure you're always paying attention to things like that, making sure you're assessing their fluid needs, their hemodynamic, their ventilation status, all of that. You're continuously assessing those needs. And also, again, listening to your circulators, your surgeons, other anesthesia team members, and addressing any needs that need to be addressed, and changing your plan of care if need be. So again, that part, as far as, even though a nurse is, again, only chart their assessment every 4 hours, you're continuously assessing your patient, and you're continuously addressing ADLs and turning the patient and making sure they're comfortable. So again, another similarity there. I talked about the room scan that I do. You typically scan the room. And again, you can tell a lot, when you get comfortable in what you're doing, you can hear a lot that can kind of clue you into what's going on. You can hear suction, you can hear the pulse ox, you can, and therefore hear the rhythm. So again, you can pick up on a lot of things just by listening. Communication, even as an ICU nurse, is very, very vital, very important. And I've actually talked to a lot of ICU nurses who, one of the things that they say that they have grown upon in their time as an ICU nurse is being a better patient advocate by not waiting on something till like say the morning shift. Let's just say they had a need that they assessed their patient needed, but maybe they felt like it'd be better addressed in the morning when the full team was there. But they knew as the more they went through their ICU career, that was not the right approach to take. They need to address it even in the middle of the night, and to make sure they called the necessary people in to address the patient's needs right then and there versus waiting. So again, communication is key. No one can fix a problem if they don't know about it. So you really have to, again, be your patient's advocate and speak up and address the needs as they come versus waiting. Because when you wait, that's when more complications can happen or potentially lead down, into a road of more potential problems that then can arise from the problem not being addressed right away. So communication, again, I think if you enjoy working as a team, a lot of people think of anesthesia as kind of, you're sitting in a room by yourself doing anesthesia. And don't get me wrong, it's a lot more independent than what you're used to as an ICU nurse, because you're not around as many people. You're kind of behind the drapes, but you still have your surgeons there. You still have your circulators there. You still have your attending or other anesthesia provider team there to help you. I can't tell you how many times if I've been in trouble and I call out for help, I'll have 5 anesthesia providers in my room in a second. You are never alone. It doesn't mean that 1 minute, 2 minutes that you're handling a situation that's very potentially bad by yourself isn't necessarily, it's high stress, but you quickly have help that come to your side and help you. And so it's a really amazing thing to be a part of that. Again, you never will be without help. And so if you enjoy teamwork, anesthesia is a very team effort type of career. And I find that kind of relationship very rewarding. I think it can also be challenging, so again, knowing yourself and how you work best, I think is key. But again, coming from the ICU, you're going to be used to working as a team. So it's really in anesthesia, you're also working as a team with more independence, I should say, but it's still team, but it's definitely more independent than what you're used to in the ICU. A lot so. You're constantly observing and analyzing, you're coming to conclusions and you're making up plans, and you're not waiting for a team to do this, meaning this is you continuously observing, continuously analyzing, continuously coming up with a plan and different conclusions based on your own assessment. You're not waiting for the team to do these assessments. You're always doing this by yourself in the OR 24/7 when you're with that patient. And you're only bringing it to the team if you think there's something they need to come in and address as well. You don't necessarily always have to get someone involved. This just happens naturally over time, where I may, I'm maybe making it into a bigger deal than what it probably is, because for me, it seems so natural and just comes like second nature. Like I don't even think about myself doing it more than half the time, but you do it every single time. And so again, you're not waiting for someone to give you their thoughts. You're making your own thoughts, and then you're telling someone else what your thoughts are if need be. And so you're really making that judgment call. Do I need to delegate tasks here? Do I need to let my, anesthesia teammate know this is going on? Is this what's going on? Is this important enough to let someone else know about, or is it not that big of a deal? You have to make those judgment calls on your own. And so that's where I think too, the change from ICU nursing to anesthesia is a little different, because there's a lot more independent thought and decision making on what needs to be addressed and what doesn't need to be addressed, or who to address it to. And so then we're going to go into skills. So as an ICU nurse, you have a lot of skills. You do a lot of fancy life support systems, ECMO, balloon pumps, CRT. You troubleshoot those machines. You place Foleys, you place NGs, you place Convitex, IVs, you do IVs via ultrasound. I'm sure I haven't named them all, but as a nurse, you do a lot of hands-on skills. Take that, put it on steroids, and that's what a CRNA does. A CRNA not only does IVs, they do A lines, they can do central lines, epidurals, blood patches, spinals, peripheral nerve blocks. You can do local blocks, meaning like a beer block, and then mixing and titrating drugs. As an ICU nurse, you're getting your drugs from pharmacy. As a CRNA, you're mixing up your epi, you're mixing up your levo, you're diluting down your nitro. There's a lot of pharmacology involved with CRNA. And so you have to be very diligent and vigilant, I should say, when you're doing these things. And you have to really know how to not only correctly mix drugs, but you have to know how to correctly dose the drugs. And so that is a huge responsibility of a CRNA. And not to scare any of you, because you're highly trained to do so by the time you're done with school. But it is something that's a continuous, you have to pretty much stay on top of your game at all times. You have to understand the weight-based dosing, especially if you're jumping from an adult sized patient to a pediatric sized patient. In my practice, I could have a 17-year-old who's bigger than some adults, and then I could go right to a 4-month-old next, so it's a very, very different ball game, not only with medications, but hemodynamically and even respiratory wise. So you really have to make sure you're well aware of being able to bounce back and forth between various populations in anesthesia. And the other thing that makes it kind of interesting in anesthesia is, say in the ICU, you pick a medical ICU or a surgical ICU or a neuro ICU, you deal with all neuro patients or all medical patients or all surgical patients. Now, don't get me wrong. I know intermittently patients do kind of blend together a little bit. Like I know we'd have some surgical patients that were kind of more medical now. So they would come to us after they were failure to thrive or failure to wean from the surgical ICU, and vice versa. However, that being said, in anesthesia, you could be going up an OB, doing a C-section, doing a spinal for a C-section. And then the next thing you know, you're called down for a ruptured AAA. And then the next thing you know, you're having a class 1 lap appy come in on a 7-year-old. I mean, it can just swing very, very abruptly and quickly in a day of a CRNA as far as the patient population you're actually caring for. And with every patient population comes different needs. A ruptured AAA is a very different case than a lap appy versus a OB spinal C-section. So very different patient populations, very different types of cases, and you can literally do one all in one day. If you're a 24-hour CRNA, you could see all of that in one shift. So again, I think that makes our job fun. It makes it rewarding. It also makes it very hard and very challenging. But I personally like the variety. I've had people say, is your job boring? No, if your job is boring, if you're a CRNA and your job is boring, you're not challenging yourself enough. Maybe you took a job that isn't challenging enough for you. There are jobs that maybe people probably call what they call bread and butter. I don't personally believe bread and butter in anesthesia even exists, because even in a outpatient colonoscopy clinic, someone can vagal with the heart rate to 0, and now you're coding them. Stuff can always happen. So no, there's no such thing as bread and butter, but on a day-to-day basis, do all patients vagal down to a heart rate of 0 and code during a colonoscopy? No, it's not very common. So yes, the vast majority of your cases, they're quick. You do the same thing. It's very routine. So could that be boring? If it's not a right fit for you, it could be boring. But some people prefer that. Some people like that. Some people, again, need to be at a level 1 trauma center where they see a variety, like I just spoke about. You can go do OB, you can do hearts, you can do neuro, you can do kids, you can do anything. That might be the better place for you if you might get bored at a colonoscopy clinic. But again, it just depends on knowing yourself and what you want. Some people care more about their schedule than they actually do the types of anesthesia cases they're doing. And for me, I know, for example, it fluctuates with my life. When I was first out of school, I wanted to do everything. I wanted to get my hands on everything, get me in everything. I wanted everything. And I'll say right now, it's kind of impossible to do everything, by the way. I thought, okay, I want to do peds. I want to do hearts. I want to do neuro. I want to do OB. My hospital that I originally worked at didn't have any opportunities for regional. So that was one thing I was lacking. But again, it's hard to get everything in one spot. And it also is hard to become an expert at you can't be an expert at everything. You tend to need to focus and hone in on one type of skill that you really just enjoy. And that's okay. There's always opportunity later in your career to go explore, do other things. And again, priorities change. Once we had a family, did I really care about what I did? No, as long as I was happy with what I did, I don't get me wrong. I do care about what I do, but I cared more about, can I get my schedule? Because I want to be home with my children. So my priorities changed in that I don't care about money. I don't care about the types of cases I do as much. but I want my schedule. And so again, will that always be the case? Probably not. My kids are probably going to eventually, be off in college, and, maybe then will be a time for me to go back and do something different, that I, back into maybe trying to do more different various types of anesthesia. So again, I think it just depends on where you are in your life and what you want. And I feel like I went off on a tangent there, but I wanted to kind of explain to you guys some of the differences that I see. But I was speaking about how anesthesia mixes up drugs and how they see a variety of different types of patients. And now for the biggest difference that I see between a CRNA and an ICU nurse, and I also have kind of spilled the beans a little bit, as I have mentioned it a little bit earlier, was the independent thought and decision-making and actually taking action. And so, and don't get me wrong, it's not like an ICU nurse stands there and the patient's coding and does nothing until the doctor arrives. They jump in, they get in the action. I'm not saying that at all. But what I'm saying is when you're in a room running an anesthetic, you're not going to have an attending or another anesthesia provider in the room with you at all times. You are going to be the only anesthesia provider in the entire operating room, meaning in the ICU, you're never really closed off from other ICU nurses or even the doctors that, help you and guide you. You're always surrounded by people. You're never closed off in a room for hours and hours on end without anyone else there to give you any guidance. Now, that being said, it's not that anyone doesn't give you any guidance. And again, you reach out for things when you need guidance, you guys, but this is what I'm saying. You have to use that judgment call as to whether you need guidance, because if you don't, you do the case, you take the patient to PACU, everyone's happy. But if you're in a case and you're like, I don't like the way this looks, or this is a little fishy, or I don't know, this is a change, maybe I should get someone to the bedside to address this, make sure I'm thinking correctly, or maybe there's a bigger problem that I'm maybe missing. When you have those types of second guesses, or kind of like intuition, essentially, that maybe something isn't 100%, I'm telling you, 100% of the time, get someone else to the bedside. You will only regret it if you don't. It's not a big deal if you call someone to the bedside and they're like, oh yeah, that's cool. It's no big deal. Cool. It's fine. Okay, good. Sweet. That's what I wanted to hear. No one's going to ever fault you and say, how dare you call me to the bedside, because this is not even a big deal at all. This is silly. You should know this. Blah, blah, blah. No one's ever going to be like that. The patient is first. Pride is always second. Patient's always first. So I don't care how simple it seems. If you're having that intuition, and this is the intuition you build as an ICU nurse, listen to it. And so I promise you, it will come and serve you well. Oh my gosh, time and time again, it gets me, it saves lives, you guys. So this is also why I think being a critical care nurse is so vital to becoming a CRNA, because that experience, that intuition, that sixth sense that something is not right with your patient, you pick up on that by working with these really, really critically sick patients in the ICU. And so again, I really think, making those judgment calls and being there by yourself, not having essentially anyone else there to kind of reassure you that you're making that decision call, but you have to then call out for that. I think you get that from working in the ICU, but you get thrown into that day in, day out as a CRNA over and over and over and over again for big things, for little things. And so you're always, again, not only assessing and making independent decisions, but then you're also deciding whether you need to escalate it or not, and then who to escalate it to. So again, you're taking action. And as I mentioned before, when something bad happens, or when something unexpected even happens, it doesn't even have to be bad, but it could just be unexpected. You're right there in the thick of it at the head of the bed, and you set the mood, you set the tone. Meaning if you're freaking out, if you're like, the whole room is going to freak out. So it's really important as a CRNA and as an anesthesia provider to keep your composure at the head of the bed and only, escalate things as necessary. Meaning don't make a big deal if it's not a big deal. I'm not saying not to make a big deal. Of course, if it's a big deal, make a big deal. But again, you have to make that judgment call. And, most of the time you can alleviate things by either communicating with the surgeon of what is going on. Maybe they're causing it, they can stop. Maybe they're the ones causing the vagal or the blood loss or whatever is going on. Or you can easily treat what's happening to stabilize the patient and get them through it, so the surgeon can continue to work through a critical part of the operation. So, and making sure you're communicating during that time. And asking for your backup, again, saying, hey, I need to get so-and-so to the bedside. I just want a second set of hands here just in case, because you know, when you're getting in that kind of limbo land where you're teetering of like, okay, this is getting a lot and this could go down quickly. It could escalate quickly. I should get another second set of skilled hands to the bedside now, just in case. And again, no one's going to ever fault you for that. There's been times too, where say I'm waking a patient up from having, let's say they're already a respiratory cripple and they had a lobectomy. And you know, their end tidal is a little higher than I'd like it. Their tidal volumes are not as quite as, you know, they're iffy. They're like borderline. Are they going to fly with extubation? I don't want to extubate them, have to re-intubate them. You know, so call someone else at the bedside to lay some eyes on them. Say, what do you think about the way they look? Do you think they look like they're weak from too much paralytic still on board, even though I've reversed them, even though they, you know, don't have a fade? You know, again, trying to rule out differential diagnosis. You think it's guppy breathing because they're in a lot of pain? Are they stomach breathing? You know, getting someone else's opinion is never going to hurt anything. So, but it's still you. It still falls on you if you make that decision to extubate someone, and then now you're in a crashing situation where the patient needs to be emergently supported and re-intubated. So again, that could fall on you, meaning you're the one choosing to extubate. You're the one choosing what drugs to push. You know, there's times in a case where maybe something's happening and you're choosing to do a certain treatment method or hang a certain drug, and you're not waiting for the, you know, someone else to get to the bedside to ask for their permission. You're doing what you know is best for the patient, but you have to own that. You have to own that decision. So you see what I'm saying? Like if you're stringing up Cleviprex, well, you better have a good rationale, and they better not walk in the room with a pressure of, you know, 50/20. And why weren't you not titrating that correctly? So again, you kind of, as a CRNA, you have to own your decisions and own your treatment methods, because you're the ones taking action and doing things right then and there. And again, as a CRNA, you're putting in orders and you're ordering insulin drips and you're titrating and you're judging how much insulin to give. I never followed the insulin protocols during my open hearts because it was usually too aggressive. And these patients are not even on tube feeds. They're not on dextrose. You know, it's way more dangerous to have low blood sugar than it is to have high blood sugar. Not that you want crazy high blood sugar, but a blood sugar of 40 can kill someone's brain cells, you know? So again, being a little more lenient with a sliding scale insulin and using your own judgment based on what, you know, the patient needs. See what I mean? You don't really follow protocol. You're kind of going against that and being a little more cautious when you're treating someone with high blood sugar during an open heart case. So that's what I mean. You're kind of making these decisions on your own in the OR and maybe going off what is standard protocol. Okay. The same can be said for titrating pain medications. You're the one who's in complete control of titrating someone's wake up. No one's going to be happy if we're on the table 45 minutes after the end of the case and the patient is still not breathing. What did you give them? So, you know what I mean? You're taking ownership with how much narcs did you give them and why did you do that? So that's probably the biggest difference I see between ICU nursing and CRNA, is the fact that you really are taking full ownership for your actions and titrating medications to the patient appropriately. All right, well, I hope you guys found that insightful and helpful. I look forward to seeing you guys next week for next week's episode. Have a good one. Bye-bye.